So now what you could do is quiz yourself if you'd like to, and you could kind of block out a couple of these and say, hey, can I come up with the right answers? If it was live in class, I would do that to you. So I want you to do it. And one of the quizzes I often do with people, you can probably eliminate facet if you want to, but for your life you need to know that. So one thing I would do is I would often in class kind of eliminate L5, L5, L5 and say, hey, what facet's going to put pressure on the L4 nerve root? And you'd have to say L5. I'd say, okay, what the L5 nerve root, what discopathy would cause the problem? You'd have to say L5 again. And then I'd ask you, hey, with S1, what disc, I'm sorry, I did that wrong. I'd say what facet, then I'd ask what IDF for L5, and then I'd ask what disc for S1. And you'd have to say L5, 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 and it scares you when it's the same thing several times in a row. And I don't blame you, it would me too. But there are a couple of things up here that I really want to talk to you about, and one is the biceps. Okay, now when we get into the testing and Ben's in the room, if you've already done that and looked at that on the video, is fine. But we will be doing it with you, where we talk about how we're going to test C5, C6, C7, C8, and then finally T1. But if you'll notice, I kind of shy away from bicep testing. You certainly can do it, but it wastes your time during the test and it's worth no points. And here's the problem. If the C5 is weak, if the bicep is weak, is it C5 or C6 nerve root? There's no answer. But if the abductors are weak, what nerve root? C5. We've got an answer. So this is worth its weight in gold. This is worth its weight in gold to do wrist extensors. Now, bicep deep-tenon reflex, that's owned by C5 nerve root. So I want you to be a master at bicep. Make sure that you practice this, and I'll show you how to do them. If you haven't been to that video yet, you will certainly go through that together. So I want you quizzing your nerve disc IVF. You can do that out here. I want you practicing these. We're going to go through how to do a dermatome very carefully with you so that you're picking up the cotton ball, having the patient shut their eyes, etc., etc. And then make sure you do your deep tendon reflexes. Now, I do want to note that there is an L5 medial hamstring reflex that we've got to learn to do. Some schools learn it, some don't. So I'll make sure that we've practiced that on the video as well. Also, I want you to take a look at this. Tibialis anterior, okay, is how we're going to evaluate L4. Extensor hallucis longus is L5, and we're going to use the gastrocs and soleus for S1. Even though I know some schools use the glute med for L5 and the glute max for S1, and you can add all that to the test, but there's no extra points for it. You're chewing up time. It's hard to get the patient to do that. It's awkward. They fall down. So we're going to talk about how to do everything that you see up here, either seated or supine. Nobody's going to crawl on the floor to take care of any of this stuff in the lumbars. So if you haven't seen that video, buckle up and we'll do that together. Now in the meantime, let's see if you can be my expert in court. Alright, so let's say I've got this C6 nerve root problem, and I want you to be my expert and confirm my findings. So I was just wondering, I'm giving you the case ahead of time, what muscle test or motor test would you have done for C6? Oh, you're going to do wrist extension? I did that too. That's great. Okay, so we're going to agree on wrist extension here. Biceps, maybe, yes, maybe no, but wrist extension, absolutely. Okay, what would your dermatome be? Oh, you're going to do the lateral forearm in the first two digits. Great, that's what I did. Lateral forearm, first two digits. Perfect. Okay, what are you going to do for the reflex? The brachioradialis. Yeah, that's what I did. Brachioradialis. Okay, then we're in perfect agreement for myotome, dermatome, and DTR, the correct package for the C6 nerve root. Great. Then I'm going to send you my next case. Okay, I'm going to court. I got this T9 nerve root. So, what is your muscle test? Oh, I heard some thunder. Maybe somebody's trying to help. Okay, so I'm going to tell you right now, the muscle test is the B-Bors test. Remember, B-Bor can be used from T7 all the way down to T12. We have the person do the sit-up, and we're looking where the belly migrates, and that'll tell us if we have a motor problem from T7 to T12. So we can get a lot of mileage out of that, can't we? So B-Bors could have been used for T7, T8, T9, T10, 11, 12. All right, so what's your dermatome? Now, you better be able to do that. Now, you know what the umbilicus is, right? 10. So this is a segmental band right above the umbilicus. Okay, so a segmental band just above the umbilicus. Okay, what's your reflex? Tickle, 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 tickle. What's that called? When you tickle all four quadrants? T7 to T12, abdominal reflex. So the abdominal reflex can get you a lot of mileage from C7 to T12. We don't have much consistent for the upper thoracics, but T7 to T12, you have motor and reflex answers. You have BVORs for motor and abdominal reflex for the reflexes. So dermatomes are just a matter of knowing them. Now, if we go over here, what are you going to do for this case? I always love asking this one. S2, S3, S4 nerve roots, what's your motor test? And don't you dare say squeeze my finger, okay? Don't look at me with that tone of voice. Okay, so when we're talking about this is the motor test is just basically asking the patient, can they control their bowel and bladder function? Start, stop. So that's all that was, okay? Well, didn't mean to make it tricky, but you do need to, struggle through it once. The dermatomes, now, don't say the word target or bullseye, okay? All right, now if we leave those words out and don't put those in reports, then what words can we use? Well, perianal circumference, circumferential rings, the circumference of the anus, that kind of thing. That kind of language would be okay. How about a reflex? And that's where we irritate the anus and it winks at you. Now, you're not going to be asked to do that on the test, but you do have to know the name of these. So that's the anal wink. Now, finally, at the bottom of the page, I'm not going to read this stuff to you, but if you don't know your referred pain patterns, if the patient says their sternum hurts or it hurts at T10 in the back or epigastrium, then you really should learn these and go through those and make sure there's nothing there missing. If they describe pain to you, you should have a pretty good idea whether it's muscle or circulation or joint. So make sure, if especially if English second language, just spend some time here and make sure that we're sharp on all these. All right, hopefully you find your way back to 43. If not, pause, get there. Now, as we look at 43, I call this page miscellaneous because I just didn't know where to put these things or kind of what to call them. And so I think, can't you agree, myositis ossificans, where do you put that? You can have it in the bicep, you can have it in the quads, because these get hit and traumatized. Usually this will resorb, but it's a leave it alone lesion. And we used to say 3 to 6 months, but we're kind of expanding that to 6 to 12 months. It might even take a good year and a half for this kind of resolve before you can really be adjusting them. So it is a leave it alone. You don't compress, you don't ice, you don't heat, you don't ultrasound. There's no right thing to do to this because it's really little tiny shards of kind of glass out there in the muscle, because it's little flecks of calcification, and it's not good for you to do anything to it. Let the body resorb it. That's the right thing to do. All right, TMJs. Now that could be caused by the dentist. Maybe they put new bridge work in or something and it's not seated well, so even if you adjust them, they're not going to get better. So of course we want to take care of this, but it's good to find the origin, maybe find out if there's stress or grinding, what we call bruxism in their life, but adjustments definitely, you and the dentist kind of figure it out, and usually we can get to the bottom of that. Now, costochondritis. Okay, let's talk about where this gets confused. Okay, how many chests you got? You got one. One chest, where's the middle? Right here, it's sternum. Right? Your sternum is the middle of your chest. Okay, how many chest walls you got? 2. You got, well, let's just do one hand. 2. You got 2. You got a chest wall here and you got a chest wall here. So where's the center of your chest wall? Midclavicular, midclavicular. So when somebody says anteromedial chest wall, or the middle of their chest wall, what they're saying is this area right here. And that's where the rib and the cartilage meet. And the rib and the cartilage can get irritated and inflamed by kind of doing motions like this, clipping, that kind of stuff. Michael Jackson used to dance that way. So, that was kind of the beginning of it. And so he had a case of costochondritis, so that sort of brought it to the forefront. Somebody famous gets it, then we all figured it out. But anyway, we can adjust this, help this. Now here's what I did. I took costochondritis and some other things, and I put them in this rib lesion diff dye, and I kind of made it easy for you to kind of get some of the basic words that go with the pain, whether or not you care for it. So if you'll bring that up, Dr. Laura. What we're talking about is costochondritis is on the front. All the others are pretty much, fracture can be wherever you fractured it. But subluxation usually going to be from the back. The pain's going to go around to the front. Intercostal neuritis is typically from the back to the front. Herpes zoster is typically lesions on the front, but the pain is back to the front. So this kind of just explains what maybe pain words would be appropriate. Obviously, a fracture would be local. Subluxation is going to be radiating. So the language might help you a lot. And then, of course, everything up here we take care of with the exception of fracture. And so I think nothing newsworthy there. Scapular, I threw in flaring and winging so you remembered who was rhomboids and who was serratus anterior, but Again, that's not a big part of this test either. Now, what I did do down here is I took two things that I want you to compare. I want you to compare polymyalgia and polymyositis, then myofascial and fibromyalgia, and then tendinitis and bursitis. Okay, so we're going to make some comparisons. So let's look at these two first. If I covered up that word rheumatica and just asked you what's worse, polymyalgia or polymyositis, doesn't your mind say polymyositis? That right? Inflamed, infected? Okay, you're right, this is worse, but it doesn't mean inflamed, infected. And if you want to, you can write the word in here. It means dead. It means muscle is dying. That word itis just gets misused a lot, doesn't it? Okay, so itis then in this case means muscle death. And we're not going to take care of, as the primary care provider, if somebody that's losing muscle death is happening throughout their body. And this would be things like muscular dystrophy or maybe inborn errors of metabolism like McArdle syndrome, things like that. So obviously somebody's got to get to the bottom of that, and then maybe we'll be co-managing the case. But we're going to refer it out probably to the neurologist. Let's figure out what it is, and then we'll all decide what we're going to do, okay? Then we've got polymyalgia rheumatica. Now some people have this as the primary condition, but basically in chiropractic school, the one we talk about that the patient comes in with all these achy joints is usually that autoimmune condition called giant cell arteritis. And what we're concerned about when they have these achy joints all over is that they might get that temporal arteritis headache, which means that they could be inflaming that ophthalmic vessel and causing blindness within a short period of time. So as much as we can adjust them, we also want to co-manage them with the ophthalmologist if that does occur. Now, not everybody has temporal arteritis that has giant cell, but they do have these giant cells, and the SED rate is very high. So we'll see a SED rate of usually over 80. So I always say they have a SED rate over 80, but the patient's over 50, because this is an older patient typically. Okay, so polymyalgia rheumatica usually an older patient. Polymyositis is usually a younger patient. Okay? We can keep polymyalgia. We referred polymyositis. Now with myofascial and fibromyalgia, I thought we ought to stop and have a moment here. Myofasciitis or myofascial nodules or myofascial anything, okay, is associated with trigger points. Where are those trigger points? Fibromyalgia, remember, is determined by 11 out of 18 tender points. So what's the difference between a trigger point and a tender point? If you push here, and I kind of hurt in this general area, that's a tender point. But if you push here, and I say that refers pain up into my shoulder and my shoulder blades, that's a trigger point and has a reference zone. Okay, that means that there's probably lactic acid buildup. We've got to break those adhesions up, those little lactic balls. So we've got that trigger point that has to be kind of beat to death. That means we're going to put ice on it afterwards. Okay, so we call that combo therapy, that we do some and then ice you. So that's usually combination therapy, and that's due to that muscle spasticity. Versus fibromyalgia is going to be somebody that's just tender all over. They have these really active neurotransmitters. They just hurt. So wherever you touch them, it's just sore. And often this person is getting very little sleep. In fact, there's a big debate on whether the sleep deficit causes the fibromyalgia or the fibromyalgia causes the sleep deficit, but they are in a very vicious loop of just not feeling well. And so obviously we want to do some nutritional things. We want to talk about sleep hygiene. We want to be adjusting them. And heat is the only thing that's going to feel good here. If you ice that, you'll never see them again. All right, then we've got tendon versus bursitis. Now, I don't know if you paid any attention, but this was on the first page of musculoskeletal exam, and now we're ending with it. This is the very last thing we're going to do here. So the tendon, okay, tendinitis means that you've gone out abused, and probably torn some. So that is brace, rest, and ice. Versus the bursitis is the altered biomechanics. So now some time has passed. They're kind of using trick muscles to get things to happen. And now we've got pinpoint tenderness and ow, and we got to get in there and adjust that thing. And whether you do ice or heat will probably be determined in your office, but I would probably say heat on this test.